Geriatric psychiatrist is a physician who specializes in the diagnosis and treatment of mental health issues in older adults, typically 65 and above. Geriatric psychiatrists in general collaborate extensively with other medical providers and familial systems. We are really trained to be on multidisciplinary teams. It is how we believe we can be most effective. It's how we think naturally. So when we're, formulating a case or thinking about a presentation, we're always incorporating those aspects of our training. And I think that works very well because these cases are exceedingly complex.
One unique aspect of being on an E-MDT in general is that we all have different perspectives and we all teach each other different things. We hear from the district attorney about what is actually prosecutable or whatever,
Right.
Things like that. I'm sure this happens with you where you're reading a case and someone says, oh, they've got some cognitive problems. We are more able to kind of like ask specific questions about that, see if there was testing that was done, if there was a workup about dementia, and kind of explain to people too that even if there is a diagnosis of dementia, right, that doesn't mean they can't testify.
Right.
That doesn't mean that we can't do anything about it just because there's dementia, and educating about the different stages of dementia or what kind of problems you might look for, other testing that you might do, and explaining to the team what it means may really move the case in a different direction. And I think that's really a big benefit of having a geriatric psychiatrist who knows these different kind of things that can happen.
Absolutely. We will get these reports and then they'll come to some conclusions and we'll have to kind of explain how they could potentially have come to those conclusions. And also in those, they usually specify a diagnosis and then have some medications, and we can speak to dosing considerations, side effects that could be impacting cognition, and some of the factors that we may be able to mitigate. If somebody's adherent with this medication, their capacity could change. Those types of considerations. So that's often the type of discussion that will come up in a multidisciplinary setting.
That's such an important thing that we do. I think as geriatric psychiatrists are trained to do, hopefully everywhere, is look at the medication lists, see what's really, what we think might be needed, what we think might be impacting somebody adversely, other things that we can mitigate to maybe, improve their cognitive function.
Right. My primary role is to listen to a case presentation and provide information about the mental health issues as they come up, provide clarifications. I'm often reading psychiatric evaluations and medical records and providing a professional opinion about the findings in those reports. Sometimes in cases when it's indicated, I will speak to an elder abuse victim's primary care provider to try to elaborate on collateral or coordinate care. Another thing that we do, that psychiatrists on the teams here do, is that sometimes we'll do presentations about mental health issues that are pertinent to any case, with the effort to just expand people's knowledge of the implications of certain mental health issues. So I've done one on, affective disorders and how they're treated and how they may impact an elder abuse victim, on trauma as it presents in somebody with a neurocognitive disorder or dementia. So there are a variety of different presentations that sometimes I do and people from other disciplines do, just to aid in the group's understanding.
A lot of the teaching that I end up doing is about what it means to have capacity, right? And how to ask for a capacity evaluation. Capacity is not equivalent to competence. We're looking at one single question at a time. Usually that's a medical capacity evaluation. So the question has to be pretty specific. Does the person have the ability to choose a healthcare proxy? And it can change based on person's state, what if they're taking medications, if they have an infection, if they recently had a stroke. There are a lot of things that can affect somebody's ability to make a decision at a certain point in time. Competence, on the other hand, it's a legal definition, right? If somebody is challenging someone's ability to make all decisions, right, that is something that a judge needs to make a decision about. So when a judge assesses for competence, they may take into account a capacity evaluation done by a geriatric psychiatrist at a certain point in time. But they have to look at the totality of what's happening with that.
I think capacity is one of the issues where the multidisciplinary team really weighs in. And so a conversation that will frequently come up is the APS worker will say, I really don't think they have capacity. But the psychiatry evaluation will say, nothing about, not having capacity. And so, the APS worker will say the abuse is terrible. They are very impaired. I think that we need to appoint a guardian. The psychiatry evaluation won't specifically indicate that. I'll try to interpret the findings of the psychiatric evaluation and determine, whether we need to, amend it to better reflect, as you were saying, the current circumstances as they can change. Or ask a more specific question of the psychiatrist so that when they go in to do their evaluation, they're geared towards understanding the extent of the problem, the extent of the abuse, how it's happening.
There are many times when cases get presented to the E-MDT and the case presenter kind of comes in with the assumption that they're presenting so that I can do a capacity evaluation or that a capacity evaluation is definitely needed in this case. We always step back and say to the team, what are we going to do with a capacity evaluation? Why do we need this? What is it going to show us that we don't know now? Is it going to add anything to the case? I often do the evaluations myself. And so I have the understanding and the knowledge about the case and the possible outcomes and things like that, that if you are referring to somebody who's not part of the team, they may not have all of that information available to them. If it's already very well documented in the record that there is a diagnosis of dementia, do we really need that evaluation? This might be a chance where you go and talk to the primary care physician and say, would you be willing to make a statement? You've been following this person for a long time. You've seen how she's changed over the years. Do you think you can make a statement? Are you comfortable with that? If that's the case, then maybe we don't need a formal capacity evaluation, right? It is not an easy thing to get a capacity evaluation. We are a scarce resource. There are less than 2,000 geriatric psychiatrists in the country. And if you are looking for one to specifically do a capacity evaluation, you may not find one in your community. You don't have to be a psychiatrist to do a capacity evaluation. In fact, any licensed physician can do a capacity evaluation. However, if there are questions about, cognitive function or the effect of depression or delirium on somebody's ability at a certain point in time to make a decision, then you might want a geriatric psychiatrist to weigh in on that.
When it comes to responding to an elder abuse victim, one size does not fit all. So when we're thinking about an individual, we are, we're collecting so much information, both, indirect and direct contacts, and then often reaching out to, people who are leaders within their specific community or organizations that specialize in treating people of their ethnicity or religion to try to best understand how we as a group should intervene, and how somebody with that specific background would respond to an intervention from any specific agency. I think the primary benefit for me is being part of this diverse multidisciplinary team of individuals who have expertise in working with vulnerable older adults. And those relationships, extend beyond the walls of the meeting.
I almost feel like it's my mission in life that I need to help. The people who are victims of elder abuse need help, whether they know it or not, whether they acknowledge it or not, right? And I feel like, just as a member of this society, I need to do what I can to help. And I just happen to have this specialized training and I can do this.
Personally, I feel inspired and moved by the work that everybody does and can do coming together. And I think, particularly now when, burnout is common and we all are working hard, to have that is, incredibly meaningful for my work.